Good morning, everyone, and welcome to the Information Technology Committee meeting. I would like to start the meeting today. First, I think, Kim, do you have some comments?
Yes, I can. Thank you very much. Whenever you're ready, we're ready to provide the information technology update for the last quarter of calendar year 2021. We also have a resolution today, which we would be presenting. Shall I begin?
Yes, please. Already, Colicia, you made a note that Karen St-Hilaire is representing Commissioner Gary Jenkins and Matt is representing Dr. Katz.
No, that was before the meeting, so you need to do it on the record and you need to approve the minutes for September 20th.
Okay, so sorry about that. Well, I would like to note for the record that Karen St-Hilaire is present, representing Commissioner Gary Jenkins, and Matthew Ziegler, representing Dr. Katz, both in a voting capacity. Next on the agenda, I would like a motion to approve the minutes of the Joint Medical and Professional Affairs and Information Technology Committee meeting held on September 20th, 2021.
So moved.
Thank you, Dr. Calamia. So I'm going to call each member for their vote. Is Jose in?
He's not here as of yet. He'd be joining shortly.
Okay. Matt?
Aye.
Okay. Karen?
Right here.
Okay. Do you vote in favor of accepting?
Yes, I do.
Okay. Dr. Calamia?
Yes.
Okay. Feniowski Peñamora also vote yes. So the meeting minutes is adopted. Thank you. Next, we will have the CIO report and an informational item from Ms. Kim Mendes. Kim?
Thank you, Penny. Our first slide here is just to provide an overview of our calendar year 2021 goals and the alignment with our strategic pillars. And we'll make reference to this as we provide our update.
Thank you.
Today's agenda, I'll begin with an introduction. I'm Kim Mendez. I'm the CIO for New York City Health and Hospital. To my left is Apoorva Carrier. She is our AVP for Finance and Administration. I have with me also Jeff Lutz, who's our Chief Technology Officer. Across from me is Sean Koenig, who's our Chief Application Officer, and also Dr. Michael Boughton, who is our Chief Medical Informatics Officer. Joining us and supporting us today remotely is Shoma Badori, who is our Chief Informatics Security Officer, and Keith Pelby. Our overview today will look at some of our targeted end of year updates for clinical informatics. Additionally, will be our data center migration, which is a significant project for us. And then we will look at our clinical and revenue cycle applications, some of the key accomplishments in the last year, as also some of our next steps as we enter 2022. And then we'll close that with an update on our enterprise support services survey, which is part of our continuous quality improvement. And then I would like to just acknowledge some of our teammates and their key accomplishments over the last year. So I will turn over to Dr. Mike. Let me do the slide, behave myself. I'm going to actually start with this slide, Dr. Boughton.
Great.
This looks at one of our key metrics, which is our biomedical device integration across our system. Mike?
Great. And to give you guys a flavor for this, what this is bringing our medical devices into our network and into the electronic medical record, so our nurses and our PCAs don't have to be manually writing down the information machine and then hand pecking it into a system. So it takes away manual effort from those individuals, and it actually gives our providers and nurses more up-to-date information to be making clinical decisions on. So what we've done here, and you'll see, the yellow bar is the light green or light blue bar. What we've done is those are the machines that we've updated or upgraded. And so this is, if we had a cardiac monitor that was older, we've put in a newer, higher functioning monitor and reintegrated it. The dark blue is the net new machines that we've integrated for the year. You can see we had a revised goal of 1,700, which we've surpassed. This is a major win. This is a major win for our clinicians. And it's also, it represents a good partnership, because this was between IT and the clinical side and the business side, because what this shows is that we adapted to the business need and the clinical need as the year went on with our revised goal. Go to the next slide, please. So this slide is on the Gold Stars, which is an Epic program to judge how many of the features that are available to all Epic customers have been adopted here at New York City Health and Hospitals. We were at level 5 at the beginning of the year, which is right around the 50 percentile for nationally, and where we've moved is to 8 gold stars, and where this puts us, and if you can go to the next slide, is in the top 25% nationally. And you can see on the right side of the screen are other institutions that are at level 8. During our briefing, we discussed what other organizations that are safety net institutions are at level 8. And after reviewing this year's numbers, there is no other safety net hospital at level 8. So this is a real achievement for us. And to give you a flavor of what this means, the kind of feature adoption, one of the things that we put in this year is the week of a patient's birthday, we send them what their gaps in care are for the year. So if you're due for a mammogram or you're due for a colonoscopy, we're proactively reaching out to those patients that need that service and telling them about it. We're not waiting for them to come to New York City Health and Hospitals during their annual visit. We're telling them this needs to be done with the hopes of closing more of those care gaps and meeting the quality metrics that are so important to us. Go to the next slide, please. So Honor Roll is a similar program to Gaps in Care, also an Epic program. The way I'll differentiate the two is the Gold Star is, did you build the features? Honor Roll is how many of those features are actually adopted and in use. We've done a very good job here as well. At the beginning of the year, you can see on the left side of the screen, we had a lot of at-risk features. We've completed almost all of those at this point. We are under the final review with Epic right now for this program, where middle of this month, we should get a final verdict, whether we passed for the year or not. I'll give you that update next time. I do anticipate that we will pass hitting 5. There's 8 categories overall, and we're going to hit in 5 of them. So it's the eligibility, the ease of use, data analytics, health information exchange, pop health, and staying current. So that's great. You can see the patient experience we don't anticipate hitting for the year, and those are at risk. And on the next slide, we get into some of that. So there's the 3 ones, and I'm going to be relatively quick here, so please ask questions if you'd like. But there's something called Fast Pass, which it allows a patient the ability to sign up for the waiting list to get an earlier appointment. So if you want to see your doctor and they say your next PCP available appointment is in 3 months, but something pops up in a month, we will send them a text message or a MyChart message saying there's an appointment available. This is scheduled to go live in conjunction, later this month, but is not live yet. Hello Patient, similarly, is also going to be going live shortly, but is not on right now. That's a functionality that will go live to the hospital. You don't need to go to the front desk to check in. The patient can let them know from their MyChart account that they are there and ready to be seen and fill out a lot of their paperwork digitally on their device. The last one is the patient message handling. This is an area where we have made a real focus to improve, but is an area that we really do need to improve. This is if a patient sends in a MyChart message, how long do we take to respond to that message? This is usually done by the provider. We're at around 63%, about 63% of the time we're responding within 3 days. We really want to get that up to 80%. This is a top priority, not just of this part of the organization, EITS, also of the Ambulatory Care Leadership Group, and the MyChart Steering Committee has made this one of the 3 metrics they're going to target this coming year to try to improve. 7 of our sites have site-specific MyChart. All of our sites have MyChart-specific steering committees. 7 of them have chosen this particular metric as the metric that they are going to be focusing on performance improvement. So it is something that we really do want to improve on. So I just kind of focused on the negative side of what we had trouble hitting for the year. There's far more features that we actually did get on, and that's why we're going to hit honor roll for the year. So we made our vaccine clinics way more efficient through express lanes. It puts all the right documentation in place, puts all the right education in place, and makes it a quicker process for the provider and a more standardized process. We also really worked on our benchmarking to make sure that not only do we look at how we are doing at H&H and how all of our sites are doing, but how we're doing nationally on all the different metrics. So there's been.
I'm sorry. Can I
yeah.
interrupt a second? Just to follow up on the patient messaging. So is there a process in place where there's sort of a triage of these messages, or do they go straight tasked to the provider?
The way it's set up is that the message comes in, it goes to a pool. That pool is monitored by a nurse. And if it is a patient refill, it'll go, if it's a prescription refill, it'll go to one area. If it's a scheduling question, it'll go to scheduling, and then it will get passed on to the physician if it's not one of those and it's appropriate for the physician to answer.
And then after the physician gets it, is there some mechanism to be able to follow through on timing of when it's done, or some reminder, or is there any other player in that system that's making sure that there's a follow-up at that point?
Yeah, so it goes to the physician's in basket. The physician gets an alert that it's there. They don't get a subsequent alert that they have a message, but every time you log in to Epic, you see how many uncompleted in basket messages you have to attract attention to it. And the different sites have different means of reminding the physicians that they have messages to respond to.
Yeah, I guess it's just a question of, if you're going to address that issue, then how are we following up when somebody's queue is getting very large, not attended, whatever. So
yeah,
I guess that would be,
yep.
I guess what you're working on, but it'd be helpful to know if there's some mechanisms in place for that.
So there are reports that look at the individual's response time, what their typical response time is to MyChart messages, and also how long messages have been in both the individual's queue and people overall at that hospital. So the answer to your question is, we do have analytics that can break down both at the enterprise, the site, the department, and the individual basis how responsive they are being.
And lastly, just making sure that urgent messages that get there, there's somehow some mechanism of making sure it's not just left to chance that the provider, especially if they've got big queues, to make sure that that's followed through on. Or do we make it clear we don't accept sort of these very urgent messages on the system?
There's very prominent messaging that if it's an emergency to call 911 for a second. If it's not quite an emergency that you want to call 911, but you want to be seen immediately, we have virtual urgent care, and then we put what the expected response time is of 3 days in the up front. So we do set the expectation that this is not going to be responded to immediately.
Great, thank you.
This is Mitch. I'm just thinking about, can you guys hear me?
Yes.
I was thinking about the question in terms of how it works at Gouverneur as one example. When the nurse, so the messages first go to the pool, as has been explained, and then I'll sometimes get a message forwarded from the nurse because it's a question that he or she cannot answer, or it's not a refill. In those cases, do we have what I'm not sure of is whether the pool nurse responds back to the patient and says, I forwarded your question to your provider. He or she will get back to you as soon as possible for those questions which are really not urgent, right? I mean, the interesting thing about these messages from patients is some really require immediate response, and sometimes they really don't, and even the patient acknowledges that. So what would be good would be if nurses did respond to those, such as, okay, I forwarded your message to your provider. I'm sure he or she will get back to you as soon as possible. That then should count if it's not an urgent message in terms of responding to the patient.
No, that makes
Does
sense.
that make sense?
Absolutely.
Yeah, that does make sense. We can check on how it's actually configured. I won't venture a guess. I think if there is a response, but it's still sent to the physician in basket, I'm not sure how that's handled. Sean, are you familiar?
My guess is that it's sent, just judging from the messages I see, and it may be different in different places. But my guess is that if a patient asks a non-urgent question, like, can you order my lab before my next appointment in June? The nurse will forward that message to me. But if I answer it in a week, because after all, it's not urgent, they're not going to go for labs until June. If I don't answer it for a week, that would count as a week. And really, if the nurse has forwarded it to me, that would really be not a good characterization of responding to the message.
Yeah. No, this is true. And I think that is part of our reason that our goal here isn't going to be 100%. There's certain scenarios that don't dictate an immediate response. So we will look at that specific, whether the nurse response would pull up, whether that counts. But our goal wouldn't be 100. Our goal, I think, what the MyChart steering committee set out was as a goal was 80%.
Understood.
Mike,
For a
Thank
lot of
you.
those issues.
So Mike, I'd like to, for Dr. Calamia, I know we're talking about data and metrics and following this up with a rigorous way, but I do have an anecdote. So my son was seen in dermatology clinic at Bellevue, and then he had a recurrence of his complaint, and he utilized MyChart, stated that he had the recurrence of his symptoms. He was contacted immediately and was seen the same day. They had him come in the same day. Now, he posited if his last name were not Allen, if his last name was Jones, would he get the same response? I don't know. But they were able, regardless of his last name, to respond and give him a ticket, an appointment to be seen the same day, all through MyChart. So I was actually very impressed.
Yeah.
I think for the story, because it's so critical that there are, when we say 80%, versus 100%, it's extraordinarily difficult to get 100%, but you kind of do need 100% of those that there really are acute issues that if there's no further follow-up, we've well documented that the information the patient got to us was semi-urgent. I guess my concern is let's just make sure that the system, because those, we do need 100% response by somebody to make sure that that patient is either told,
Have
no,
follow-up.
this is something that requires you to go to the emergency room, call 911, or it's sent to another provider potentially if one is not answered, or some supervisory component, because I hear you. I mean, I think those are great responses. I think it's been spectacular what you've done so far. But the two-edged sword here is we've well documented when patients have an issue, and we're well documenting if we're not getting a turnaround time, particularly if it ends up being a serious problem.
Yeah.
I mean, this
So
is
I think
fair.
that's really my major concern here.
Yeah, we all agree. The reason that the ACLC, our ambulatory group, takes this so seriously, the sites and the MyChart Enterprise Steering Committee all think this is a top priority for the coming year. And I just to put it in the context, a few years ago, we didn't have this capability. And frankly, the MyChart numbers, the activation rate has improved so much over the past year or two, or the past 2 years, that this is something relatively new to our providers that is a work in progress, and we are getting better on all the time, but it's not exactly where we want to be yet. This will be a focus for us this coming year. So I'm happy to take more questions on this. Yeah, please.
I just want to follow up, since we are here in the topic, is that in the protocol, let's assume that the nurse cannot answer the question, okay? And those are going to be the most challenging ones. Does the nurse send a response to the patient saying the doctor will get, so at least the patient knows that somebody has read it and it is now in the hands of a doctor or someone else? What is the protocol for that?
Right now, it's the individual's decision, but we can look at putting in a response for the nurse to like to include that, like where it would go out to the patient saying that's being forwarded to the doctor. I think right now,
Yes.
I shouldn't say that. Right now, the nurse can respond, but there's nothing automated that I'm aware of.
So it's not
Okay.
standard practice right now, I think is really, and there's an opportunity for us
Yeah.
to work with the team, to develop that. Good.
I think
Good
it will
point.
be good to add that as a standard procedure because, the patient want to know, did this go to a void or somebody read it and there is something happening with it? So I think maybe that would be one of the best practices that we can suggest is that if a nurse read it and cannot answer it, at least let the patient know that, it's being forwarded or the doctor will be back to them or something like that. Just that the patient knows that somebody read it and is working on it.
Yeah,
There's a response.
agreed. That makes sense.
And we can bring that follow-up back here as well.
Yes, we will.
Okay. Thank you. Since we are in this topic, and I just want to make sure that I have the chance to everybody ask about this, and then we can continue. Sorry about that, but Jose, do you have any question about this issue of the patient? Because I know that this is a very important issue that we all care very much about it.
Not at this point, but I mean, same sort of like comments and concerns, or not concerns, but comments that you all. So thank you.
Thank you.
Mhm.
I know, Dr. Cass, you made a comment. I don't know if you want to elaborate anything else.
I would just say that, Benny, the issue that you raised shows that the more complicated issues are not really technology. They're clinical practices, right? The technology can support anything. It's making the clinical practices work well. Thank you.
Yeah, I agree, and that's what I'm saying. Like, maybe making suggestions to the nurse. But I agree.
Yeah.
The culture is a lot more difficult to change than a computer code language line. Karen, do you have any question about this topic?
No, I do not.
Thank you. So in that case, Dr. Calamia, is there anything else that you would like to add to this discussion?
No, I appreciate your highlighting it so well. And, I guess the follow-up will be really helpful, but I don't want to lose track of the fact this has been a great accomplishment and bravo to everyone involved. But again, as you accomplish great things and the technology's there, as Mitch said, we got to make sure the clinical component is able to keep up. Otherwise, we put ourselves in some more liability in many ways. So, but thank you. I appreciate that.
Thank you, Dr. Calamia. Dr. Barton, you can
Great.
continue.
Great. So on this slide, it goes through our activation rate for my chart. We're at 70. We finished the year at 72%. That puts us firmly in the top 10 percentile nationally of the public safety net groups. The average is 44% nationally, and we're at 72. So we really done a very strong job on this. When you look on the left side of the screen, it's the activation rate by site. All of our sites are above the national average. And in the appendix, what we've done is there are sites that have not fared quite as well on the activation rate. What we've done is we've shown their improvement over the year. And they've all improved. Everyone in the 50s and 40s that started the year, they've improved double-digit numbers across the year. So there really has been solid movement. And the way this is the most general, and the way we did not, this is the data that is not cut at all. When you look at more refined data, so look at patients that have a primary care provider within our institution, the activation rates are far higher, and who are the leaders change. And so, when you look at this, it might look like some of the folks at the bottom are not doing quite as good of a job, but they're doing a really good job for their own patients that are routinely being seen in that institution. So this is, I gotta say, the MyChart activation rate is just a win. And the reason it's a win is we set up the right technology, but it was championed by the registration clerks up front. It was talked about by the nurses. It was talked about by the providers during their visit with them. This was a team effort to get it to this point, and it could not have been done without all of us working very closely together. If you go to the next slide, this shows how many times the patients are logging in per year. We had a nice blip up in December. That's not statistically significant, but I think what you're seeing here is it tells a story that patients are using MyChart, and they're not just signing in to get their test results once or twice. What you're seeing is consistent use throughout the year, and that's a win. So, in December, it's 6.5 times a year was the average of our MyChart users. This is pretty good engagement. We want more of this. So I talked earlier about the MyChart steering committee. We've done a really good job of activation rate. What we now want to do is keep patients engaged. Going back to it, one of the ways is to respond timely to messages, to put more relevant information in the chart, and that's all what we're doing here. Also, we're setting up, we've been using more and more of our video visits that are integrated through MyChart, so you don't always have to come in person. And on the topic of video visits and setting up MyChart is this slide, which is our, patients. MyChart is a wonderful tool. It is really quite easy to use, but there are parts of it that can be challenging to our patients. And what we wanted to do is provide them an outlet, a phone number that they can call if they have questions. And what you see in this bar graph here is how many phone calls a month we're getting from our patients on MyChart and the support we're giving them. And this has really been fantastic. We've been able to do this for our patients. And what you see here is it generally coincides with the different COVID surges, where people have questions, they have concerns, they're calling in to get help with their video visits, having trouble or concerns about their test results and understanding them. So we have not only a very easy to use MyChart application, but if patients do have questions, we now are in a position, it's past a while, but in a position to support them. That's it for me, Kim.
Okay, thank you, Mike.
A question. I have several patients who do contact me by MyChart, and their message is in Spanish, which is great. I don't have any difficulty reading it. But what do they actually see? And same question for like Mandarin patients, our common language. Are they, when they log into MyChart, are they seeing a background that is in their language, or how does it work?
Yeah. English and Spanish, they are seeing a background in Spanish. I believe we're working on Mandarin right now. I have to tell you, Epic as a vendor is not as far along in this path as we need them to be, and it's someplace that we are both pushing them to go farther, and we are developing ourselves to go further. With as far as other languages. So Epic has, I think, English and Spanish natively. They also have a number of European languages, I think, Finnish and Spanish, Finnish and Dutch, which isn't really helpful for our patient population. So we needed to do more work to develop MyChart in those other languages. I think, Sean, Mandarin is being finished. Simplified Chinese. Yes, I'm sorry. Simplified Chinese is being implemented as we speak. I know also up on the list is Bengali. But no, we're not. It is English and Spanish right now, and we're working on developing the rest.
And even thinking again, and I should know this, but like so to me, my Spanish-speaking patients are writing in Spanish, and I'm understanding and writing back in Spanish. But what if they had a provider who normally used translation services? How would it work?
Yeah, that is the translation of text automatically is not happening. That's not happening at this juncture. That is something that is certainly on our roadmap for the future, but that is, the ability to automatically translate text from one language to the other is something that has not been ready to consistently and reliably do this for us.
I agree. The technology is not there, certainly not about sensitive information. I'm just thinking what would happen. I guess what we would hope is that each clinic would have a native speaker read the notes and then tell the provider if the provider wasn't language concordant, what the patient was looking for. Is that what we would? Again, as you can see, the hard questions are clinical process, not technology.
Yep. And what you described is what? Oh.
I'm just thinking, so maybe that's also another thing that as we work with the clinical processes to be sure that that's what's happening.
Translation on site. Right.
And what you described is what has been described to me is what's happening. Okay. People read the message. You can always call an on-site interpreter to your room to help you respond to the message, and I know that does occur.
Could I just ask
Get
then,
this- yeah.
how decentralized is in fact the initial triage, I guess we can call it? Is that every site having specific
Yeah.
people? Okay, so there is no
It's
easy way of making sure that we would literally have to make sure, as Dr. Katz said, every site had someone who's competent in
Right.
in
And you
reading and
probably want
interpreting.
that. You probably don't, Vince, you probably don't want it centralized. I mean, like at Gouverneur, it's not even Gouverneur, it's my medical team, which is appropriate, right? You want a nurse who knows how the doctors are functioning and who has some idea of the patient to be reading it. So my messages go to the group 3 or practice 3 medicine nurse at Gouverneur. Now they have a pool, and there's a Spanish-speaking nurse, there's a Mandarin-speaking nurse, so whoever is in the pool would get my message and then forward it to me.
Yeah, I agree with you, Mitch. I think that makes much more sense to have it localized in that way. But then we do need to make sure that at any specific site, if there's not people competent at interpreting, that we have some mechanism in place to make it an easy matter for them to have it interpreted and the message followed through in some fashion. So again, as you say, it's not the technical here, it's trying to make sure we have, the personnel in place that can competently handle that. So thank you.
Thank you. Thank you for all the feedback, and we will provide some follow-up in both of these key areas. Our next area is focused on our data center migration. This is a 2-year project, began in May of 2021, and we are on track to complete this in May of 2023. Jeff, I'm just going to go to the next slide. If you could just provide a brief update on where we're at from an overall perspective.
Sure. Thank you. And yes, briefly, so as you saw from the previous slide, that we continue to remain on track. We're a little over now, a quarter of the way through this project. And as you see here, this is kind of the goal here is to give you guys a little bit of a better visual representation of the overall project plan, as well as point out some key milestones and achievements. The 2 items that I will highlight very quickly is the first one is in partnership with Shoma, our CISO. We have stood up and certified the data center. So we have established connectivity to QTS, our first one, which gives us the green light to start moving applications in. And we are currently working very closely with the application teams to plan out when those applications will move. Between April is when we anticipate the first ones, through August. And we will be working very closely with the application teams, as well as communicating those out to the business. And just as a quick reminder to that, the goal is, as in anything that we do, is to make it as seamless to the end users as possible. And the good news is that a lot of our applications are virtual in nature, meaning they're not tied to the equipment. So we will not have to shut the applications down as we physically move equipment from one data center to the next. So through this process, it'll allow us to do this in a lot more of a seamless fashion. So as we finalize those details, as we go through that this month, we'll have more to share.
Right. Thank you very much, Jeff. And Sean, I'm going to move over to you from a clinical revenue cycle application perspective, maybe some highlights of the accomplishments.
Yeah, so thanks. I'll try to be brief. We've continued our support of the COVID vaccine and testing sites. Specifically, we were able to include our sites in participation with the city's $100 incentive program for people receiving their first doses. Additionally, lots of stuff on this slide here, but I'll point out that we implemented some decision support, reducing unnecessary and repeat lab tests in our inpatient areas, partnering with the quality office to make sure that our patients were getting the best care possible. Also, we're continuing our path towards standardization, implementing QPath for point of care ultrasounds across the facilities in ED and ICU areas, as well as standardizing nurse call systems to improve our patient care experience. Next slide. Upcoming over the next few months, we have a lot of things going on. Actually, yesterday, it's now in the past, we did our blood bank HCLL upgrade. Everything seems to be going well. a couple of small issues that we're continuing to track, but things went well this weekend. Improving our effective use of H2O in Epic by implementing Wisdom, which is Epic's dental module. That's happening this July for the first sites, as well as Willow Ambulatory, partnering with our pharmacy colleagues to move towards a retail pharmacy module. And that's going live first at Lincoln and Kings this May. So those are some highlights. Thanks.
Thank you very much. Moving on to one key area of our continuous quality improvement initiatives we're focused on. We began a customer service survey, which began in April of 2021. You can see here we used a very straightforward 5-point Likert type scale with different smiley faces and then an option for free text. And once an individual has called our support desk, such as the My Chart that Mike showed previously, then they are sent an email to fill out the survey. And to date, we have sent out over 845 survey requests, and we've had about a 5.15% response rate. And overall, I'll bring your eye to the bottom right here. We are at about 94%, 95% almost, overall customer satisfaction. So we will continue to provide these surveys and, provide an update as we move forward. For the last part, I did want to just highlight some of the key accomplishments of our teams, just ensuring all of the progress that was made that was mentioned today and supporting our facilities and our enterprise with ongoing COVID surge. We did hold in conjunction with Natalia Sinius, our 9th annual Nursing Informatics Conference that was held in October of this past year. You can see our team at Metropolitan was the team of the month, which was information technology, boots on the ground there at Metropolitan Hospital. That was last November. Our EITS clinical applications training team, really responsible for all of the onboarding from an EPIC training and access perspective through all of our surge and our just onboarding regular full-time employees. They were acknowledged as the amazing team. And then our teams who are actually clinicians over this past year, dozens of our EITS staff who are clinical volunteered to temporarily be assigned throughout our system. You can see 2 of our staff members here, one a nurse, which is Neil DeLuca on the right in the vaccination center, and also Zana Michael, who's a pharmacist, who also supported the vaccination center at Elmhurst. And then I'll just, Frida George actually was a winner of the vaccination, prize giveaway. And James Carr, he's our IT site director over both Bellevue and Lincoln Hospital. And he is a retired Master Gunnery Sergeant who was recently named to the notable veterans list in Cranes. I will pause there and thank you very much and open for questions before we move to the resolution.
Thank you, Kim. I really appreciate it. So let me call each member to see if they have any questions about your presentation. Jose, any questions?
I have no questions. Thank you so much.
Thank you. Dr. Katz?
Thank you.
Karen?
No questions.
thank you.
Thank you.
Thank you, but no questions.
Thank you. Dr. Calamia?
No questions, just comment. Again, spectacular work. Obviously much to be done, but great work. Thank you.
I would like to also second Dr. Calamia's comment. The IT group has been doing amazing work. I know that all the units in the hospital system has been tested with the different ways of COVID, but your group has been really there to support the needs, provide the data that allows them to make decisions in a very timely fashion, as well as looking toward the future, providing the systems that prepare us to continue to serve our patients to the highest level of excellence. So thank you so much for all the work that you, Kim, and your team has been doing throughout this year. Thank you.
Thank you, Penny. And now we can, oh, sorry, Penny, sorry.
Now, I know that you have an action item that you would like the board to consider. Please, could you read the resolution for the record and proceed with the presentation?
Yes, thank you. So the resolution authorizing New York City Health and Hospital Corporation, the system, to execute agreements with each of the following vendors. Momentum Resources LLC, Dyntech Services Incorporated, GCOM Software LLC, Experis US Incorporated, Siri Info Solutions Incorporated, Integrated Resources Incorporated, FK4, Incorporated, Stellar Services Incorporated, Spruce Technology Incorporated, the CJS Solutions Group LLC, also known as the HCI Group, Tech Systems Incorporated, 314E Corporation, Jevity Consulting US LLC, OST Incorporating Staffing Services, W3 LLC, also known as Healthcare IT Leaders LLC, the vendors, sorry for all of that, for the provision of information technology supplemental staffing services as requested by the system. The agreement shall be for an initial term of 3 years with 2 one-year options to renew solely exercisable by the system and with the total amount over the combined 5-year term not to exceed $283 million. So I'll turn to the presentation. Okay. So as we continue to recruit, for our current vacancies and meet the flexibility needs of both short and long-term projects, EITS is presenting this request to enter into contract for supplemental staffing. The current 17 requirement contracts for IT supplemental staffing will expire at the end of June 2022. New York City Health and Hospitals conducted an RFP to identify the vendors that will provide competitive pricing and the expertise in providing sufficient, well-performing supplemental staff with the requisite technical skills, and expertise in healthcare information systems. As an option, EITS did conduct a detailed analysis of the workflows and the process that were provided by the system's managed service provider, which is Right Sourcing. And due to the nature of some of our funding, we're using capital and CRFP funding, EITS has to comply with certain requirements for external reporting, timekeeping, a major one is also filling to ensure that we have fulfilled the task of our SOWs. After a due diligence, we worked for about 4 months with our managed service provider, all working with HR and supply chain. We have decided to move forward with transitioning moving forward to transitioning to independent vendors through the RFP. I'm going to move to the next slide. Okay. So the benefits of the contracts would allow New York City Health and Hospital, IT, as well as other areas in New York City Health and Hospitals, data and analytics being one such example, to have quick flexibility and align with some of our changing technologies in response to some new business needs. It's important to note that the vendors will provide as needed labor for a wide variety of technology, with a wide variety of technology expertise. The payment will be based on the actual services performed as pursuant to the work order. The vendors will be required to comply with New York City Health and Hospital onboarding and offboarding. Just to point out that we've ensured that there's a alignment with our COVID vaccination requirements to work at New York City Health and Hospital. And also there is no minimum requirement of payment to the vendors if we do not use their contracts. I think it's important here to, just pause and discuss, our staffing within EITS. We have worked over the past several years to transition to fill our vacancies and also support the quick turnaround. Particularly, our vendors and supplemental staff were key in ensuring that we were able to respond to many of our COVID surge in a very positive way. That said, one example would be with our EMR. Previously where we were at a 60-40 60%, meaning 60% were supplemental staff and 40 were FTE. Our goal was to move to 80-20 in that area, and we have accomplished that goal. Our future goal is to move to 85% FTE 15 and an ultimate goal of 90-10. I also think it's important to understand we will never not need supplemental staff, that we do have, short and long-term projects that would lend themselves to be supported in this way. We've also embarked on a new recruitment strategy with our HR partners so that we can move forward with filling some of our current vacancies in this area. I am now going to move over to the overview of our procurement process, and I'll hand over to Apoorva Carrier.
Thank you, Kim. So this is the overview of how we went about with the RFP. It was posted on City Record in September. We invited 41 vendors directly. 59 vendors attended the pre-proposal conference. We evaluated 43 proposals. We did an initial scoring end of December, and the scoring was finalized early January. Next slide.
Sorry.
We are selecting shortlisting 15 vendors that Kim previously mentioned of the 43 vendor proposals. I'm not going to go through the list again. Next slide, please. So this is a summary of the vendor pool. All of our vendors that are shortlisted have more than 5 years of experience providing healthcare staffing services with an annual revenue sales of $5 million. While each vendor has different competencies and specialties, all of them are able to meet the specified staffing needs in the RFP with an approved MWB utilization plan and/or certificate. All the hourly rates that were provided by the vendors were measured against the industry standard and our current rates in order to ensure competitiveness. The vendors demonstrated competency in IT project strategy and delivery. The evaluation committee, during our rounds of scoring and discussions, reviewed the vendor performance for the incumbents, and the reference checks conducted by strategic sourcing were very successful. So this is really an overview of how we went about with the RFP. The criteria that are outlined on the top left are the minimum criteria, included MWB utilization plan, prior experience in large healthcare IT businesses, a minimum annual revenue of $5 million, as well as their ability to fill specific roles when needed through subcontracting with MWB vendors. The criteria that we scored the proposals on was 30% based on experience, 30% cost, 20% organizational capability, and 20% MWBE. What I did want to point out here is generally RFPs have a 10% MWB scoring. We did provide, we increased the scoring criteria for MWB to 20%, considering in order to leverage the MWB opportunity in this space. The evaluation committee had representation from various programmatic teams within EITS, including the clinical information system, enterprise infrastructure, business application, and enterprise support, as well as groups outside of EITS, including quality and safety and HR. It's a little small to read from here, but this is really the profile of all our vendors, the MWBE utilization commitments, which is at least 30% or above, and the subcontractors that they have provided in their MWB utilization form that they plan to utilize for the contract period. The next slide, please. So EITS worked very closely with the vendor diversity team to develop the RFP and the scope of the RFP in order to maximize MWB participation. As part of this efforts, as I mentioned previously, what we did was we increased the MWBE scoring, quantitative scoring, to 20%, which is usually at 10 for a number of other RFPs. In addition, what we clarified right up front in the RFP that H&H as well as EITS will have sole discretion to manage the solicitation process among the awarded pool of vendors to increase MWB participation. This will allow us maximum flexibility while we're awarding this work. And down on the bottom are some of the criteria or some of the solutions we're considering to increase MWB participation. EITS and the diversity team will work closely to ensure that all the vendors comply with their MWBE goals, at the minimum 30% MWB utilization amongst the pool. Some of the tools that we are considering in initial stages of discussion is quantitative scoring on all solicitations, conducting closed pool solicitations for certain appropriate staffing titles, and some discretionary awards while we monitor this contract. EITS and the vendor diversity team will periodically report to the board IT committee on the MWB performance of these pool of contracts.
Okay, thank you. In closing, New York City Health and Hospital, EITS, seeks Information Technology Committee approval to enter into a 3-year contract with 2 one-year renewals at the discretion of New York City Health and Hospital with each of the following: Momentum Resources Solutions, DiTech Services, GCOM Software, Experis US, Siri Information Solutions, Integrated Resources, K-Force, Stellar Services, Spruce Technology, CJS Solutions Group, also known as HCI Group, Tech Systems, 314E Corporation, Jevity Consulting US, OST, W3, also known as, excuse me, Healthcare IT Leaders, for an amount not to exceed $283 million. Reemphasizing that the term will be from July 1st of 2022 through June 30th of 2027, with the estimated cost through the contract's renewal term to be $283 million. No minimum usage required, and also termination for convenience is at the discretion of New York City Health and Hospital. I will pause here.
Thank you, Kim. Thank you. Let me ask each member for any comments. Jose?
No questions or comments. Thank you so much.
Dr. Katz?
No comments, thank you.
Karen?
No comments.
Other project management software.
What was that?
Dr. Calamia?
No questions. Thank you.
Okay. Kim, I just have a question, well, a comment. I really appreciate the effort that your team has taken to really position this RFP in a way that increase the participation of a diverse pool of vendors, and also with the how much thought you have put into organizing the moving forward as the contract is being implemented or being utilized, and the way that the vendors will be provided assignments. That again increases the participation of diverse vendors. So I just want to thank you for you and your team for the work that you're doing on that. Now let me ask for the vote. Jose?
Yes.
Dr. Katz?
Yes.
Karen?
Initiative
Yes.
designed, developed, and work.
Dr. Calamia?
Yes.
I also vote yes. So the resolution passed to for us to forward this request to the full board. Thank you. Any old business that we should be discussing? Any new business? There being no further discussion, all in favor of adjourning this meeting?
Aye.
Yes.
Yes.
Aye.
Yes. Thank you. So this meeting is adjourned. Thank you, everybody. Thank you, Kim and your team. Thank you, Jose, Dr. Katz, Karen, and Dr. Calamia. Have a wonderful day.
Bye.
Thank you all. Same to you.
Bye-bye.
Take care.